Hi, Kate here from CCDR. Today we are presenting the results of the PEAK study in CLL that was conducted with an Australian population in 2020. We'll be going through the report section by section, but only just touching on different aspects of the report. It's quite a long report, and you can access that through our dashboard where you can read the whole study, or you can go through section by section depending on which parts might be of interest to you. This particular study was generously supported by AstraZeneca Australia, and we want to say a special thank you to our community partners who helped to share the opportunity for participants to register for the study, particularly Neil and Joanna Matthews, Health Unlocked CLL Group, Lymphoma Australia, and the Leukemia Foundation. So this PEAK study includes 70 people diagnosed with CLL throughout Australia, and it has a qualitative and a quantitative component. It's the largest CLL study of its kind reported in Australia. In section 2, this is where you can find information about demographics and also information about the baseline health status of this patient population. So we had 70 participants in the study, 45 women, 25 men. 47 people were from a metropolitan area and 23 from a regional or remote area. There were 33 with a university education, 37 with trade or high school qualifications. It was exactly equal for high socioeconomic status and mid to low socioeconomic status. And most of the participants came from the eastern states of New South Wales, of Australia. Damn it. Hi, Kate here from CCDR. Today we are going through the PEAK study in CLL that was implemented in an Australian population in 2020. I'll be going through the report section by section. You can read the whole report on our dashboard. This is what the dashboard looks like, so you can read the full report or you can go through section by section depending on what's of interest to you. This particular study was sponsored by AstraZeneca. We're very grateful for their support, and we'd like to thank the community partners that helped share the opportunity for patients to participate. In particular, Neil and Joanna Matthews, Health Unlocked CLL Group, Lymphoma Australia, and the Leukemia Foundation. This PEAK study includes 70 people diagnosed with CLL throughout Australia. It includes a qualitative, structured interview and a quantitative questionnaire. And it's the largest study reported in an Australian population. In section 2, you can find information about the demographics of the cohort that participated in this study, and also information of the baseline health status of this cohort. We had 45 women, 25 men participate in the study. 47 were from metropolitan areas and 23 from regional or remote Australia. 33 people had a university education and 37 had trade or high school qualifications. It was exactly equal for socioeconomic status between high and mid to low, and most of the participants came from the eastern states of Australia. On average, when we did a structured interview with each of the participants, it took 53 minutes and 41 seconds. When you look through the study, you'll be able to see that we present the results with subgroup variations. So this means you can always see the result for the full cohort of people in the study, as well as the breakdown between the stage of disease, gender, education, age, location, and socioeconomic status. In terms of baseline health for this particular cohort, on average, the participants reported generally poor health. In section 3, this is where you can find information about symptoms and diagnosis. It's also information about the diagnostic tests that were performed and who performed them. And there's also information about the participants' understanding of their condition and understanding of prognosis. So this is the results of a question asked in the online questionnaire where we asked participants to check which symptoms they had before diagnosis. So all of the symptoms they experienced before diagnosis. The most common ones were fatigue and swollen lymph nodes that were reported, and also excessive sweating at night was reasonably common. We also asked patients to rank their quality of life while experiencing different symptoms. So on this Likert scale from 1 to 7, 1 is life was distressing and 7 was life was great. So overall, if it's a lower score, it means a poorer quality of life. So those symptoms that received a rating of poorer quality of life than others were things like fatigue and shortness of breath, neutropenia and thrombocytopenia. This next question is about what actually led a patient to be diagnosed. So this is what we ask in the structured interview. What led you to going to see a doctor to get checked out? So the main symptom that led a patient to some type of investigation was fatigue, and that was followed by a lump in the throat. In terms of where they went to get diagnosed, most of the participants described being diagnosed through their GP, and then this was often then referred through to a specialist. This is a question that we ask participants about what they understood about CLL when they were diagnosed. About 75% of the participants in this study said that when they were diagnosed, they really knew nothing at all. And this was followed by just having a limited understanding. And this is important for clinicians and for healthcare workers to remember that when a patient's diagnosed, they don't really often understand what the condition means to them. And it's often a shock, so we need to take that into account when we're providing information and communication. Another important question is about prognosis, so what your outlook is. Most of the participants understood their prognosis in the context of watch and wait, either on its own or with the understanding that they would maybe need treatment in the future. There was also just over 20% of the participants that really felt they didn't have an understanding of their prognosis. This is a graph that represents the diagnostic pathway for people with CLL in the cohort. So the blue line is all of the participants, and the red, grey and black are the different stages of disease. So as you can see, for the most part, it's a similar diagnostic pathway for each of the stages of disease. You can just see some different blips on the black line, which has been AC. In section 4, this is where you can go for information about decision-making, how patients make decisions and whether decision-making changes over time. The first question is about the discussions about treatment. So not what treatments patients had, but what was discussed when they were diagnosed. So 40% of the participants said that they really had no treatments discussed. And then just under 25 said that there was discussions about possible future treatments. In terms of those that had a specific discussion about treatment, most of those described chemo as a general treatment rather than a specific treatment. In terms of what patients are thinking about when they're making decisions about treatment, over a third described that the treatment's efficacy, how effective the treatment is, was the most important thing to them. Just under a quarter of the participants described really relying on the advice of their clinician. Under 20% described symptom relief as being really important. And close to 15% were talking about the ability to either maintain or go back to work. This is a question where we ask participants if they feel that decision-making changes over time. So just over 45% of the participants said that they felt like the way they made decisions changed over time since diagnosis. Some of those reasons were because they felt they were more cautious and more considered, and others felt it was because they were more assertive, informed. Others again felt that it was because they were more aware of their own health responsibilities. Close to 50% felt that the way they made decisions hasn't changed since they were diagnosed. And the main reason for this was because they had always been informed and assertive. This is a really important question. And we asked participants, what their own personal goals of treatment and care are. So just under 35% of the participants said that the symptoms that their goals of treatment were to reduce or control symptoms and limit any side effects. Just after that, over 25% of the people said that their goal was to maintain their current health and quality of life and also avoid treatment in the future. Some lesser themes were around being able to live a long and normal life. Some people found this question hard to address, and there were a number that also noted that it's not really a conversation that they'd had before, so they found it hard to answer. In section 5, this is a really big section in the study. So if you're interested in understanding what treatments patients have had, also where they've accessed treatment, information about private and public systems, side effects, what people consider mild and severe side effects, access to allied health, and those kind of things, that's all in section 5. I won't present it all, it's just some highlights, but this is where you go if that's information that you're interested in. So one of the questions we ask is, do people feel like they were treated with respect in the health system? So 51% said yes, they felt like they'd been treated with respect. There were 38% that felt they were treated with respect overall, with maybe the odd occasion where they felt they weren't treated with respect, and 11 people that overall felt that they hadn't been treated with respect. Now, within the health system, people access the public and private system. So this is some information if you're interested in health system access of the different breakdown of how people have accessed care for CLL. Affordability, of course, is really important, and we want to understand whether people have had to delay appointments or throughout their treatment. So for this particular cohort, most of them didn't have situations where they weren't able to access the care they need due to affordability. Where there are some changes, I just have to move across so I can see the screen, where there were some differences and changes in work status are important to this particular patient population. And as we saw, there were a number of patients that their main goal of treatment was to be able to continue to work. So here on this screen, what we can see is that there's a number of people that have had to leave work or have leave without pay or access superannuation early due to the CLL. We've also got some work status changes with the patient. Changes in work status is also really important to this patient population. And as we saw earlier, there are a number of people whose main goal was to be able to continue to work or go back to work. So one of the most important things on these slides is just to note the number of people that had to have leave from work without pay, leave with pay, or to access their superannuation early. There's a reasonable number of people here that had had their work impacted by CLL. Section 5. Section 5 is where you can go if you're interested in the treatments that people with CLL have experienced. Also their experience of quality of life around those treatments, their understanding of the effectiveness of each treatment, also information about their perceptions of side effects, and all of the allied health professionals that people have been able to access. The first question we ask is about respect that people have received throughout their whole experience in the health system. So 51% felt they had been treated with respect overall. 38% said they had been treated with respect, perhaps with the exception of the odd occasion, and 11% felt that they hadn't been treated with respect overall. In terms of how people access healthcare, in the Australian system, people can be private or public patients and within the private or public systems. So this is just information for those interested in health system usage and how the patients with CLL access the various types of health services in Australia. Affordability is also really important within this patient population. And within this cohort, most of the people reported that they never had to delay or cancel appointments due to affordability. So that's good news. Work status is also really important to this patient population. And as we saw earlier, there are a number of people whose main treatment goal was to be able to maintain their work or go back to work. So here we have in the top table, one of the most important things to note here is that there were really over a third of this patient population that said, because of CLL, I had to leave from work without pay or with pay, or access superannuation early due to CLL. This is just to point out that in the study, we collect all the information about what types of treatment people have had. So this is just a rundown of what people have been able to access. But if you want to go deeper into this information, for each treatment that patients have, they give a rating of quality of life while on that treatment, any side effects that they've experienced, and also how effective they felt each treatment was. So this is a figure that shows the treatment pathways for people with CLL. Like the diagnostic pathway, the blue is for all the participants, red is for BNA-A, grey stage B, and black stage C. So you can see the different treatment pathways for each of the stages of disease compared to all of the participants that were in the study. In terms of allied health, access to allied health, the most common form of allied health that was accessed was physiotherapy. A number of people were able to access a psychologist or a dietitian, but overall there wasn't a lot of referral to allied health professionals within the study cohort. In terms of lifestyle changes that participants made themselves, the most common lifestyle changes were exercise and also changing their diet. Complementary therapies were accessed by participants. Most commonly, people took up mindfulness or relaxation, supplements, so vitamins, minerals, and also massage therapy. Clinical trials, of course, are very important in the health system. This is the result of questions that we ask in the online questionnaire. So it's a mixture of whether people have had a conversation about clinical trials and also whether they've participated in a trial. So in terms of patients that have never spoken about a clinical trial, never talked about a clinical trial, there were just over half of the patients that hadn't had the opportunity to talk about a trial. The other half of the patient population either brought it up themselves or their doctor brought it up. In terms of actual participation in clinical trials, there are only 6 participants that had participated in a clinical trial. In the study, we asked the participants to describe what they think is a mild side effect and what is a severe side effect. So participants give general descriptions of what they would think is a mild or severe side effect, and they also describe the specific symptoms that they would categorise in each category. This is really important for particularly for clinicians, for us health professionals to understand that, if we're saying something might be a mild side effect, that might have a different definition to what a patient thinks. Adherence to treatment, of course, is important. And in this patient population, this cohort, most of the participants, just over 40%, said that they would stick to treatment as it was prescribed without giving up on it. There are just over 20% that said they would keep to the treatment as long as side effects were tolerable, and just under 15% that said they'd stick to the treatment as long as it was working. Patients in this study were asked if they had a preference for having treatment at home or at hospital. Just under half said that they preferred treatment at home, and just under 30% said that they preferred it at hospital. Some of those reasons for treatment at home for that preference was because it was more convenient, and also the reduction in risk of infection. For those that had a preference for treatment at the hospital, the most common reason for this was that they felt that they could be more closely monitored should something go wrong. If people did have treatment at home, some of the support that they would need is to have someone to call, including out of hours. And others felt that if they had treatment at home, they would definitely need it to be administered by a health professional. This is another important question that we ask patients. So we ask them, what do you need to change to feel like a treatment has been effective? So most of the participants in this study reported needing to see a blood test, so needing to see their test results to really feel like a treatment was working. Others described needing to have improved energy levels, including improvements in shortness of breath. And then some of the less common themes were around reduction in pain, reduction in lymph node size, and just general side effects, generally feeling better. So if a treatment worked, what would that mean to participants? Most of just over a quarter of the participants reported that they would be able to remain physically active, they'd be able to have more general stamina. A little over 20% said that they would be able to continue activities of daily living and just maintain their current lifestyle if treatment was working. And then there was just under 20% that also reported being physically active, but specifically in a sporting context or exercise-related context. So wanting to be able to participate in community sport or go to the gym, things like that. We're also just over 15% of people that felt if treatment works, that's going to improve their mental health and their anxiety and around the condition. And here's this theme again around the importance of being able to continue to work. So this is a slide that we've put together that brings in that combination of if a treatment worked, what would it mean? So this is one just that you might like to look back on after the presentation if it's of interest to you, to see the correlation between when treatment works and what it means to patients. In section 6, this is where we look at communication and information. So this is a really useful section for people that are responsible for developing patient information and providing information to patients. So this is another graph that you might want to go back to. It's a really important graph. It shows the gaps in information. So the way that this graph is generated is that we ask participants first to answer a question about what information they have received. What are the subject matter that they've received information in? The next question is then, once you've received information, what did you still go and search for? So it shows us some of the gaps in what information hasn't been given very freely in the sector, and then also what is important for patients, what are they still searching for. So the Partners in Health scale is a measure of overall knowledge and coping and confidence for participants, for patients. So on average, this cohort of patients had an excellent overall knowledge, coping and confidence for managing their own health. So this is interesting when we think back of that question where we asked participants, when you were diagnosed, what did you know about your condition? And most people said they knew nothing. And then when we measure that understanding of disease now, they've done really well to find information and understand their condition, have a good overall knowledge of managing their health. So this is where people have been accessing information, this Australian population. Most people rely on the internet for their information, and that includes charities as well. There's some really strong online support groups and forums that participants get their information from. And then some specific health charities as well were mentioned. So I just note that not every patient will mention a specific charity, but where they did, these are the ones that came up. So what information has been helpful? This is where we ask participants, when you've come across information, what's been the most helpful? So in this patient population, the thing that has been most helpful is other people's experience, that peer-to-peer education and support. Information about treatment options has been really helpful. And of course, being able to have the time to talk to your doctor or specialist. Information that hasn't been helpful, most of the people, half of the people in this study said that there wasn't really anything that wasn't helpful. And there were some that felt like the description of other people's experience and unsolicited advice was often felt as not helpful. There was also the theme of sources that aren't credible. So sources that aren't evidence-based, people found those sources weren't helpful also. This is a question where we ask the participants about their preference for accessing information, whether online, talking to someone in written form or in the form of an app. So the most common theme is that mixture between online information and talking to somebody. So I think we always have to remember when we are presenting information to patients that online information and written information is all great, but we also always need to back that up with giving patients the opportunity to actually talk to somebody and bring questions back to them. The reason for some of these preferences, as I've just mentioned, is being able to have that time to ask questions and clarify things with talking to people. Accessibility was the main reason for the preference for access to the internet, as was being able to digest the information at their own pace. So timing of information is really important as well. So this question we ask participants, not when they received information, but when they felt they were most receptive to taking information in. So just under 25% of the participants felt that they were always able to take information in from the time that they were diagnosed. 20% of the people needed a little time to digest the news and weren't able to take much in until after the shock of diagnosis had subsided. And there were also close to 20% that just said from the beginning, that's when I wanted the information. That might dissipate over time, but it was at the beginning, it was most important to them. Health professional communication, this is a question that we ask how patients have felt communication in general has been with their health professionals. So for this population, just under 60% felt that it was overall positive. Some had a couple of occasions where it wasn't great, but still overall positive. And there were just over 20% that had an overall negative experience. Some of the reasons for the positive or negative response, so where it was negative, it was because there was limited information. So not because it was bad, it was just limited and possibly not forthcoming. Where it was positive, it was where there were holistic conversations that took into account all different aspects of the patient's life. Another reason for negative information was that time restrictions and not having enough time to discuss their condition with their clinician. Section 7 is around care coordination and the care and support that patients have been able to access. So in this section, we use a care coordination tool, and it's a validated tool measuring how well people have been able to navigate the health system. So the average score for this patient population shows us that they had moderate communication, navigation, and overall experience of care coordination. So while they had good knowledge, their ability then to navigate the health system is probably an area that the participants, the patients in Australia, might need a little bit of help with. Where are people getting care and support from? So most of the time, people in this study said that they were getting care and support from family and friends, and that's quite common. Charities play a big role in the care and support that patients receive, as do the hospitals and clinical setting. Peer support has come up again as another important area that these particular patients have found care and support. Section 8 is about quality of life. So how CLL has had an impact on quality of life, mental health, relationships, family relationships. Also, we use a fear progression tool, and that measures the level of anxiety that participants have in relation to their condition. So that fear progression tool, the highest score is 60, and that indicates a very high level of anxiety. So overall, the participants that were while on active surveillance had a mean fear of anxiety of 33.19, and while they were on treatment, a mean score of 34.44. Overall, what this corresponds to is that this particular cohort had a moderate level of anxiety in relation to their CLL. How does CLL impact quality of life? So just over 60% of the people said that CLL had a negative impact on quality of life, and there were about just over 20% that they felt like there wasn't really an impact on their quality of life. Impact on mental health, there are over 70% of the participants said that there was at least some impact on their mental health. It was only just under 20% that felt like there was no real impact on their mental health. So what are some of those reasons? Well, fear of uncertainty, not knowing what treatments ahead, also just not knowing the progression of disease. Others felt that the reasons for that were because of the constant need to deal with diagnosis, and similarly that the CLL was always on the back of their mind. So what are some of the regular activities people do to maintain their mental health? Themes come up again with people relying on mindfulness and meditation, consulting with mental health professionals, using physical exercise, and also coping strategies. So things like participating in social groups, connecting in activities, sports, and things like that. Regular activities to maintain general health. So what people have to do just to maintain their general health with CLL, staying physically active was important. Understanding limitations, so know when to stop, know when to say no, including knowing when to have a rest. So that was a reasonably strong theme between understanding limitations in general and understanding limitations in the context of needing to stop and actually take a rest, lie down during the day. Overall, the participants, there were just under 40% of the participants that felt like there had been some kind of negative impact on their relationships. There were 30% that felt like there had been no impact on relationships, and just over 10% that had found a positive impact on relationships. So some of the reasons for the negative impact on relationships were that sometimes friends and family didn't really understand the condition with CLL. And this was sometimes particularly because people looked well and were participating in work and family activities, so it was hard for people to understand that they also had this condition. And there are also 10% of the people that said that that impact on relationships was because it causes general uncertainty or worry within their family unit. This is a question where we ask participants if they feel like the CLL diagnosis has caused a burden on the family. So just over 50% felt there wasn't really any burden on the family, and about 25% felt like there was a burden, with just under 10% feeling like there wasn't a burden now, but they expected that it would happen in the future. Cost burden is really an important thing to understand in any disease area. There were just over 60% of this patient population that felt that in some way, shape or form, there had been some cost burden because of the CLL diagnosis that they'd had, and about 35% that said there were no cost burden. Some of those cost considerations were about time off work, whether for themselves or for a family member. And we saw those results in different parts of the study previously. Some of the other costs were in relation to parking and travel to get to appointments, specialist appointments, out-of-pocket costs for specialists, some people having to pay for treatments, diagnostic tests and scans as well. Section 9 is where we start to think about the future for the patient population. So sections 1 to 8 is a description of what patients have experienced. And in section 9, we stop and say, you're the experts. What do we need to think about for future treatments and information, care and communication? So in terms of future treatments, the participants in this study felt that in the future, they really need to make sure that the costs remain low for treatments so that people can access it. And they'd like to see treatments that have fewer or less intense side effects and that are also really safe. For information, most of the people were satisfied with the information they'd received. And as we saw with the Partners in Health score, this was a really informed patient group. Where they would like some more specific information is in that stage of disease and 4 stages of disease, how each should be monitored and managed. They'd like a bit more information on available services, particularly peer-to-peer support, which is important to this patient population. Expectations of communication in the future. So most people were satisfied with communication and had no recommendations. Where there were recommendations, it was that healthcare professionals are a bit more empathetic and person-centred, and also use more understandable language with the patient so that it's in more lay terms. Also more transparent and comprehensive. And we saw that earlier, that patients were wanting that forthcoming information from their healthcare professionals. Care and support. So in the future, where there were recommendations, again, more peer support for this patient population and access to more support services. So perhaps something we can do better is to help people navigate where support is available to them. So this is a question where we ask patients, if you were standing in front of the health minister, what do they need to know about CLL? And what's most important? So just over 30% of the people in this study said that they need to know that affordable treatments are important. There are also just over 20% of the patients that wanted to also send the message that they're really grateful for what's available. And then just under 20% had a really important message of that CLL needs to be taken seriously. This was often in the context of that patients might often present as being quite well, but they need to be taken seriously because they can be quite a serious condition. So this is a slide that you might want to go back to again. We asked patients to rank what's important to them in terms of the symptoms and aspects of quality of life that are most important to them to manage should new treatments become available. So here we can see fatigue has come up as a really common theme that's important for patients to manage, and the neutropenia as well. Also anything related to anemia. So this has been quite a consistent theme throughout the study, and not so surprising with a blood-based disease. Section 10 is about the future for patients. It's a chance for the patients that have been diagnosed to share their insights and wisdom with people in the future. So this is a really important question that we ask is, is there anything that you wish you'd known earlier? What would it be? So the main thing that patients wish they had known earlier was the trajectory of the disease, so knowing what's ahead and then knowing how to plan forward and manage their condition. That's what they'd wish they'd known earlier. There were some other lesser themes of early detection, how to identify symptoms, understanding test results, and then who to contact for information and support. Section 11, this is just to note that in Section 11, we do a review of the current landscape across CLL. So if you're interested in having a look at what's happening across all the different domains that we report on in the literature, and then we compare the results of this PEAK study to what we know in other reports as well. The final section is Section 12. So this is where our team at CCDR look at all of the results of the study to develop some recommendations. So we always come up with 3 recommendations that if we implement these, we think that they would improve the quality of life and experience of patients in the community. So the first one is the development of CLL stage and progression specific information. That needs to be comprehensive and it needs to include current and emerging treatment options. We might like to complement this by an annual patient webinar conferences so that leading clinicians can give overviews of current treatment options and management of people with CLL. Second is the development of mechanisms or services for CLL patients to access at diagnosis and during the course of their disease. So they need to be able to discuss their current prognosis, the trajectory of their disease, their support needs, short, medium, and long-term plans as well. And that's really important. Of course, any care plan needs to be holistic and there needs to be room for management and monitoring within those plans. And the final recommendation is the development of self-care and self-management tools that guide people diagnosed with CLL on how to monitor and manage their symptoms. So particularly people that aren't on active treatment, want to be monitoring their symptoms, maintaining their health, particularly between appointments, and also know any risks that they should be aware of and guidance on how to manage their health. And some of the comments that came through throughout the study was wanting to know what you need to do, but also what we shouldn't be doing when we're at home between appointments. So that brings us to the end of the CLL PEAK study presentation. As I said, the report is freely available online. And once again, we'd really like to thank all of the patients that participated in this study for giving their time and sharing their experience. We have also interviewed a number of family members, and that report will be generated later in the year.